This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Blizzard. Want to know what poison is called the silent killer? Is colorless, odorless, and tasteless, i.e. completely undetectable? How car part theft might increase the toxicity of your car? Then listen to find out. This is part of our holiday mini-series, not Hallmark style, but toxicology style. Today's episode starts in the emergency department. You're drinking hot chocolate with marshmallows and chatting. How is this possible? The emergency department is empty. Why? Because a massive winter storm is pummeling the hospital and the surrounding area. You barely made it in, and you're not sure you'll be able to get home to a house with likely no power, meaning no electricity and no heat. For now, you're enjoying the warmth and camaraderie. The hospital has power thanks to backup generators, but is operating at reduced capacity. The OR, for example, isn't open and the surgeons won't operate at all, if possible. I don't know about you, but I certainly wouldn't want to be on the table with my abdomen open if the generators fail. Unfortunately, these circumstances and difficult choices are faced by medical personnel around the world in under-resourced areas and during wars and conflicts. But this hospital is in the U.S., so we'd hope to wait until the power is back on or the storm lets up to transfer the patient to another facility. The few patients you do have are here because they need electricity for their oxygen concentrators. The ambulance doors bang open with a blast of frigid air. EMS arrives with 3 patients at once. Your colleague jumps up to take care of the sickest patient, a 50-year-old man in cardiac arrest, leaving you with the other 2 patients, a 50-year-old woman and a 13-year-old girl, both unconscious. Assisted by the nurses, you begin a quick assessment of the ABCs. The 13-year-old is protecting her airway and moving as the nurses place the IV. You turn your attention to the 50-year-old woman. She's completely unresponsive and not protecting her airway. You intubate and put her on a ventilator. Afterward, her vital signs are as follows. Temperature 38.5 Fahrenheit or 36 Celsius, heart rate 120 beats per minute, blood pressure 80/60. The ventilator is breathing for her, so the respiratory rate is good, and the oxygen saturation is 93% on 100% oxygen. You order IV fluids to treat the low blood pressure as well as labs, an EKG, and a chest X-ray. You're happy to see the 13-year-old is now opening her eyes and moving spontaneously on the stretcher. This is a good time to get more information from the medics. They report the 3 patients are family members, parents and a daughter, who they picked up from their house after the daughter called 911. They checked the blood sugars en route, if you're wondering, and all were normal. There's a lot more we need to do for these patients, but first, let's talk about the differential diagnosis to direct our workup and resuscitation efforts. Basically, we have 3 critically ill patients from the same house. What potential exposures make a whole family sick? I know the ER doctors listening have jumped immediately to the correct conclusion. This is a classic scenario we've all seen, but let's run through some options for everyone else. Was the whole family poisoned by a nefarious neighbor, or is this a murder-suicide attempt? Possible, but unlikely. I'd be suspicious about a gas in this type of scenario. How about a knockdown gas like hydrogen sulfide, which we've discussed before? No, because the medics are fine. If it was hydrogen sulfide, they'd be dead or at least ill also. It isn't an organophosphate like VX or Novichok. They don't have the killer bees or the other symptoms. Household detergents can mix, intentionally or unintentionally, producing lethal chlorine gas. This usually poisons people in smaller spaces like a bathroom or a car, and again, the medics might have noted symptoms if they'd entered without respirators. Question number 1, time to pick your poison. What is the most likely source of our patient's symptoms? A. Nitrogen poisoning. B. Carbon dioxide poisoning. C. Carbon monoxide poisoning. D. Cyanide poisoning. The answer is A. This is a classic case of carbon monoxide poisoning. Nitrogen poisoning is what you get when you scuba dive and suffer the bends when nitrogen bubbles enter the joints in the brain. Carbon dioxide poisoning can be lethal and might look similar, however you need a source like dry ice, so no, not here. Cyanide poisoning is definitely lethal, but it's doubtful that the 13-year-old girl would be improving so rapidly without the antidote. Carbon monoxide is an extremely common poisoning. Most of us have a very low risk of ever developing, say, arsenic toxicity, for example, but almost everyone is at risk of carbon monoxide exposure. More on this later. Your colleague enters to help you out. Uh-oh, that's not a good sign. You raise an eyebrow questioningly. He shakes his head, silently telling you that Dad did not survive the cardiac arrest. Now that we think it's carbon monoxide toxicity, can we test for it? Yes, for once, a toxin that's easy to test for. You order a co-oximeter. It's a blood gas, either an arterial or venous specimen is fine, and you send it to the lab. You'll get the results back in about 30 minutes. So you send it off, and question number 2, while we wait, what's the treatment for carbon monoxide toxicity? A, oxygen, B, naloxone, C, amyl nitrate. The answer is A. Oxygen is the most important treatment. Naloxone is for opioids, and amyl nitrate is part of the cyanide antidote kit. We also use hyperbaric oxygen therapy. More on this in a bit. Your colleague takes over for the 13-year-old girl, putting on an oxygen mask with 100% oxygen. Her chest x-ray and labs are unremarkable. Her mother's x-ray and labs are mostly fine, except her troponin is elevated. This is the lab test related to the heart, and it leaks out if there's damage to the heart. Wait a minute, is this a heart attack? Did we make the wrong diagnosis? It is a heart attack, but we don't have the wrong diagnosis. Carbon monoxide poisoning strains the heart. The carbon monoxide levels come back. The daughter's level is 50. Levels are reported as a percentage, so 50% of her hemoglobin is carboxyhemoglobin, meaning 50% of her hemoglobin is bound to carbon monoxide instead of oxygen. So that's not good. The mother's level is 66%, and the expired father's level is 80%. These are very high. The levels are variable, and different patients have different symptoms at different concentrations, but approximately 80 to 90% is lethal. At around 20%, patients have headaches. At about 40%, loss of consciousness and confusion. Normal is less than 5% unless you're a smoker or a New York City bicycle messenger. Then a normal level would be about 10%. Smokers are constantly exposed to CO from cigarettes, and messengers inhale CO from bus and car exhausts in crowded urban areas. These 2 patients need hyperbaric oxygen treatment. That's done in a chamber where patients inside are exposed to oxygen under very high pressure. There are single chambers for 1 person, and others are large multi-place chambers with space for several patients and a nurse. It's not available at every hospital, and often patients have to be transferred. So who benefits? There's room for debate, but generally accepted criteria include the following: any loss of consciousness, even brief, altered mental status, seizure or coma, cardiac involvement like chest pain, EKG changes, ischemia, and arrhythmias, a CO level of 25, though some guidelines say 40%, a level of 15% in a pregnant patient. So clearly both of our patients meet the criteria for HBO, or hyperbaric therapy as we call it. Fortunately, your colleague has done a fellowship in HBO, and the hospital has a chamber. Since it isn't busy, he'll dive the patients while you man the ED. Let's take a deep breath ourselves and step back to talk about carbon monoxide, where it comes from, and what it does. It's a colorless, odorless, tasteless gas and is a byproduct of incomplete combustion of fossil fuels. It's called the silent killer because it's completely undetectable. Wait, what about the smell of gas from your stove, did you just ask? That's actually an adulterant added specifically to the gas to alert people when it's left on. It's mercaptan, and it often smells like rotten eggs, so they add it to the natural gas so you can smell it. In the US and worldwide, carbon monoxide is a leading cause of poisoning morbidity and mortality. A very common cause in the US is faulty heaters, so not surprisingly, many poisonings happen in the fall and winter months. That said, there are many, many potential sources of exposure. Question 3. Running your car in the garage will likely result in severe carbon monoxide toxicity and death. A, true. B, false. The answer is B. This is actually false. It's almost a historical fact at this point. In the past, as you know, people did commit suicide and did die accidentally from car exhaust fumes in an enclosed space. But modern cars with catalytic converters generally don't release enough carbon monoxide to cause mortality. In 1975, catalytic converters were introduced in response to the Clean Air Act in the United States. And actually, we can thank this legislation for the reduction in suicide due to carbon monoxide poisoning, interestingly enough. But some people have died as a side effect of the recent rash of catalytic converter thefts. I came across a case in the news of a couple who sold the catalytic converter from their Lexus to buy drugs and then inadvertently died while sitting inside the car. It's very tragic. A lot of these carbon monoxide cases are really sad. Boat exhausts, gas ovens, hookahs, fires, gas and charcoal grills, propane heaters, and generators all produce carbon monoxide. Scuba divers have been poisoned and died from CO-contaminated oxygen tanks, and Jacques Cousteau actually first reported this in 1946 after he and a group of divers experienced headaches, confusion, and weakness while diving underwater and breathing from scuba tanks filled by a new diesel-powered compressor. CO is found naturally underground. So question number 4, historically, what alerted miners to the presence of carbon monoxide? A. Pit ponies. B. Lamps. C. Canaries. The answer is C. Canaries, and this is where the saying canary in the coal mine comes from. Animals suffer effects of CO like humans, and ponies and mules will get sick. Canaries breathe up to 60 times a minute, which in addition to their small size means they develop symptoms of carbon monoxide very quickly. An ill canary alerted miners to bad air so they could escape before it was too late. Some miners were so attached to their little birds they carried them in cages with tiny oxygen tanks attached to revive the birds after carbon monoxide exposure underground. The medics are still hanging out in the nurse's station enjoying some hot chocolate since they haven't gotten another call. They tell you the fire department checked the house after they removed the patients, measuring CO levels inside and finding carbon monoxide at 800 parts per million, which is very high, in the ambient air. They also found a generator running inside the garage. This means the dad was killed in a terrible and avoidable tragedy. Generators have to be outside, no matter the weather, unless, like the hospital, they're specially ventilated. The generator running in the garage released carbon monoxide, which built up in the closed house, killing the dad. The very generators allowing us to provide medical care in the emergency department are the same responsible for the morbidity and mortality of our patients. Worsening weather, like blizzards and hurricanes, has resulted in unnecessary deaths of many, many people who put their generators inside. In the United States, 50,000 patients a year present to emergency departments with carbon monoxide poisoning, and there are about 400 deaths per year. It's impossible to estimate the incidence worldwide, but there are hundreds of thousands of reports of deaths per year. So what exactly does CO do? Well, it binds to hemoglobin, and if it's bound to hemoglobin, oxygen can't bind. It has a higher affinity for hemoglobin than oxygen itself, and it binds 200 to 250 times more tightly than oxygen can. In patients with anemia or low blood counts, symptoms of carbon monoxide toxicity begin at lower levels. If you have fewer red blood cells, it's not surprising symptoms begin at lower carboxyhemoglobin levels. Ischemia, or lack of oxygen, is responsible for some of CO's actions, but it's also directly toxic to tissues and causes cell death via more direct mechanisms that are still under investigation. Symptoms do correlate, as I said, with higher levels, but it does vary from patient to patient, and patients with significant comorbidities like heart disease, for example, can also develop symptoms at lower levels. Question 5. What classic physical exam finding is associated with carbon monoxide exposure? A. Cherry red skin. B. Brown blood. C. Red urine. The answer is A, cherry red skin. It's a classic boards question, though in truth it's extremely rare and seen in only 2 to 3% of very severe cases. The list of symptoms caused by carbon monoxide is massive. It includes neurological problems ranging from dizziness and headache to loss of consciousness, seizure, coma, and death. Cardiac manifestations range from mild chest pain to dysrhythmias to ischemia and cardiac arrest. This is just to name a few. It's an astonishing span of symptoms. I don't think any emergency medicine doctors had trouble with the diagnosis in our patients, as I mentioned earlier. But we all worry about missing carbon monoxide in the ED. Why? Mild poisoning is more common, and it's very tricky. It looks exactly like a mild cold or the flu. Headache, dizziness, nausea, and generally feeling unwell. So it's super easy to miss. Unlike the dad in this case, the vast majority of patients do survive, reflected in the statistics I mentioned earlier, 50,000 ED visits and only 400 deaths in the US. That's really good news. The bad news is carbon monoxide exposure is complicated by delayed sequelae, specifically delayed neurologic and neuropsychiatric problems. The problem is huge and difficult to quantify. An estimated 50% of patients with symptomatic poisonings develop delayed sequelae. That's a really big number. Carboxyhemoglobin resolves with treatment with oxygen, generally in a few hours. The reason for hyperbaric oxygen is not to get rid of the carboxyhemoglobin itself, but rather to reduce the risk of developing this delayed sequelae and or to reduce the severity if it does happen. The list of these delayed problems is again massive. It includes extremity weakness and paralysis, urinary incontinence, peripheral neuropathy and blindness, also Parkinsonism, dementia, amnesia, and psychosis. Onset can be delayed for weeks after exposure, and despite treatment may be permanent. Treatment with hyperbarics works best if started within 6 hours, preventing many neurological sequelae. There is a benefit even if patients are treated later, certainly within 24 hours. Benefits thereafter are controversial. Your colleague dives the mother and daughter in the hyperbaric chamber. The mother wakes up but suffers severe neuropsychiatric sequelae and permanent brain damage and paralysis. The daughter recovers medically, but faces a long road to recovery given that her life will never be the same. This case is fictional, as are all our cases, but is based on real poisonings that occur frequently. What can you do to reduce your risk of exposure? Always keep a CO detector in your house and make sure the batteries work. I hate hearing the thing beeping or squawking about dead batteries in the middle of the night as much as you do, but CO detectors have saved my own family members from exposure. Never, ever use a generator inside, no matter what weather Mother Nature throws your way. The last question in today's podcast: where else can you be exposed to carbon monoxide toxicity? A soccer field? B, a baseball field? C, an amusement park? Or D, an ice rink? Follow the Twitter and Instagram feeds, both at PigPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Thanks so much for your attention. It helps if you subscribe, leave reviews, and or tell your friends. Transcripts are available on the website at pigpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.